Good.
Sir, we are live now.
Yes, yes.
Yeah, please go ahead.
Good evening, respected teachers. Myself, Dr. Ashish Kumar, final year from GV Pant Hospital, and with me, my batchmate, Dr. Ratul Chatterjee from GV Pant Hospital. We are presenting case today. Can I proceed, sir?
Yes.
Yeah.
Good.
Mr. A, 42-year gentleman, 10th passed, married, resident of Delhi, peon by occupation, belonging to lower socioeconomic status, presented with chief complaints of dyspnea on exertion for 10 years, palpitation for 5 years. History of present illness. Patient was apparently well till 10 years back when he started having breathlessness, which was insidious in onset and gradual in progression. Initially, it was occurring on exertion and while going up 2 flights of stairs and while walking to his workplace around 2 kilometers from home, though he was able to carry his routine activities and climb 1 flight of stairs without any breathlessness, suggestive of NYHA2. This breathlessness was progressive in nature, and for the last 1 year, he had difficulty in walking around 100-meter distance and was not able to climb up 1 flight of stairs without having breathlessness and was relieved by taking rest, suggestive of NYHA3. This breathlessness was associated with paroxysmal nocturnal dyspnea. Breathlessness was not associated with cough with expectoration, seasonal variation, not associated with bendopnea and orthopnea. For last 5 years, patient complained of palpitation, which occurred with exertion, describing as a pounding sensation in his chest, regular, gradual in onset and offset, persistent, and used to feel more in supine and left lateral position, and in quiet room, and relieved by taking rest. There was no history of post-episodic diuresis, not associated with syncope and pre-syncope. Patient also complained of 2 to 3 episodes of night chest pain, which was retroesternal, sudden in onset, waking the patient from sleep, associated with diaphoresis, and relieved within 1 hour of sitting for the last 1 year.
So what kind of palpitations are you dealing with in this case?
Sir, patient complained of palpitation which occurred with exertion and pounding sensation, suggestive of volume overload palpitations.
So how do you differentiate between an arrhythmic and a volume overload palpitation on the history basis?
Sir, if palpitation occurs with exertion, it is suggestive of volume overload, and if patient complains of palpitation on rest and sudden in onset and sudden offset, then it is suggestive of arrhythmic nature of palpitations.
Go back to the breathlessness slide.
Yes.
Yes,
So
sir.
he has been progressively increasing. He has had a breathlessness on climbing 2 flight of stairs. What do you mean by 2 flight of stairs? What is a flight of a stair?
Sir, a flight means, sir, around 7 to 8 foot steps, sir. Of
How many steps?
sir, 7 to 8 foot steps.
No. It is not. What exactly? What is the number of stairs that are there on a 1 flight, and what is the height of each step? This typically is described in the Canadian classification, but still it is used commonly for this. So they are very standard terms. So it's 10 to 12 steps. That is what is there, and height you should check. So that is one thing that is very important in this. So it has been progressively increasing breathlessness over last 10 years and palpitations. Come to the chest pain. What kind of chest pain do you think it is?
Sir, Sir, a patient complains of chest pain which was retroesternal during night time, and it was a sudden onset, waking the patient from sleep, and associated with diaphoresis and relieved within 1 hour of sitting for the last 1 year. And so suggestive of chest pain, sir, anginal chest pain, sir.
Oh, anginal chest pain, 2-3 episodes, typically in the night that you are saying, right? Or on
Yes,
the
sir.
walking, in the sleep. Okay. Go ahead. No chest pain on walking, no chest pain on routine daytime, nothing.
No, sir. No chest pain
So you
on,
want to
sir.
say that this is kind of a nocturnal angina?
Yes, sir. Yes.
Okay, chalo, go ahead.
Come to the palpitation. What have you said, Ashish?
Sir,
Palpitation.
patient complained of palpitation which occurred with exertion, describing in his words as pounding sensation in his chest, regular, gradual in onset and offset, used to persist for around 20 to 30 minutes and relieved by taking rest, and used to feel more in supine and left lateral position and in quiet room, sir. Sorry, sir, voice is not audible, sir.
Voice is not coming. So it is more with supine and lateral position in a quiet room
Yes,
and
sir.
relieved by taking rest.
Sir, a request, sir. I think आपके यहाँ, sir, you are logged in from 2 computers nearby.
Yes, yes.
That is why it's resonating the voice. So
Yes,
one,
yes.
yes, sir. It can be switched off one, then only the voice will come, sir.
Right, right,
None of the
right.
questions. So एक से log off कर जाइए, sir. एक से बात
हाँ,
कर
ठीक है,
लेंगे.
ठीक है, ठीक.
Yes, sir. Please,
Yeah.
sir.
So Ashish, you are saying that it is more in supine and lateral position in a quiet room, and again you are saying it is relieved by taking rest.
He's already rest.
Sir, it occurred with exertion, and he used to take rest and come to his room and take rest, and he used to feel more pulsation in quiet room, sir. And after 20 to 30 minutes, it relieved on taking rest, sir. That he used to feel more pounding type sensation in quiet room. It started with exertion, sir. Whenever he used to exert, then he used to have pounding sensation in his chest, and more appreciable in quiet room, sir.
Right. Okay. Okay. Continue.
No, I just wanted to ask one question to the
Yes.
candidate. What is the mechanism of rest angina as compared to the exertional angina?
Sir, during rest angina may occur as in this group of patients. Sir, patient as he complained of angina during night time, and during as patient has complained of angina due to, sir, any valvular lesion, regurgitating lesion. If patient complains of chest pain, then at night time the patient has bradycardia, and more of any regurgitation increases during night time. So they sir increased regurgitation due to bradycardia. So patient will have wall stress will be more, and there will be more chest pain as compared to on exertion. The patient, if patient complains of exertion, there will be demand supply mismatch, which will lead to chest pain at exertion, sir.
Even in this angina as well, there's a mismatch between the demand and supply. So, what are the major determinants of myocardial oxygen consumption?
Sir, myocardial oxygen consumption, sir,
Major
heart rate.
determinants. Major determinants.
Yes, sir. Sir, heart rate, and sir, depending on the, sir, what is the, sir, heart rate and cardiac output, sir.
Is that all? Anybody else? Any other candidate out there other than the presenter?
Yes, sir.
So what's the major
Yes, sir. We can include
Yeah.
heart rate, then the wall stress, contractility.
You don't include blood pressure there.
Blood pressure, yes, sir, blood pressure.
So these are the major determinants. So what is the usual requirement of the oxygen by the myocardium? How many ml of oxygen is used up per minute?
Sir, per minute, sir.
Normally.
Normally, sir, if we talk about in metabolic equivalent, then 1 to
No. We are talking
Non-metabolic
about
equivalent.
oxygen requirement of the heart, not of the patient.
sir,
Any idea what is the how do you express the oxygen requirements for the myocardium? What are the units?
unit, sir.
Have you heard of the term so much ml of oxygen
Yes.
per minute per 100 per gram of tissue? That is the units. So what is the normal coronary blood flow? How much percentage of cardiac output is coronary blood flow?
Sir,
You are aware of it or not aware of it?
sir,
What is the total amount of coronary blood flow per minute?
total
2 to 5 ml per minute and
5 ml per minute.
No,
225.
225 is saying 225 ml per minute.
So it is basically what is the weight of the heart? Normal heart, normal adult heart. What is the weight? It's about 250 to 300 grams.
250 yes.
So it is, if it is about oxygen requirements of the cardiac muscle, or the blood flow to the cardiac muscle is 0.9 ml to 1.2 ml per gram per minute. So
Yes, sir.
to really increase the demands, in patients with valvular heart disease like this, you said there's a mismatch between the supply and demand. Is there any problem with supply in patients with valvular heart disease?
Yes, sir. There will be, sir, a reduced coronary blood flow due to increased LVDP. So there will be reduced perfusion pressure in the coronary, sir. If they-
By and large, it is an increase in the demand rather than
Exactly.
increase in the flow. So increased demand, Okay, go ahead. Please go ahead. And which valvular heart disease is this very common? Nocturnal.
Aortic stenosis.
Aortic stenosis, aortic regurgitation.
No. Aortic stenosis classically is effort-induced angina. There are only
Yes, sir,
two
yes, sir.
kinds. There are only two
Chest
kinds.
angina.
One is aortic regurgitation.
Yeah, aortic.
Nocturnal angina is, as a matter of fact, they have only nocturnal angina. They rarely have effort angina.
And
Yes,
what
sir,
is
yes,
the
sir.
cause of nocturnal angina?
Sir, aortic regurgitation. Sir.
What is the cause of nocturnal angina only in aortic regurgitation, as sir is asking?
Sir, in during nighttime, patient has heart rate is normal bradycardia, so there will be increased regurgitation, which will lead to increased wall stress and more aortic regurgitation will occur. So the patient will complain of chest pain, sir, due to increased wall stress. There will be reduced perfusion of the subendocardium, so the patient will complain of chest pain.
No. Wall stress does not reduce the blood flow.
What about
Wall
coronary
stress
perfusion?
increases the demand.
Peripheral dilation occurs at night, so there is reduced coronary perfusion. There can even be reversal of flow in the coronaries in the left main zone, in the especially in the nocturnal time because of reduction of the diastolic pressure and the peripheral resistance at night.
No, actually, another cause for nocturnal angina is it is a manifestation of incipient left
Heart
heart.
failures.
Exactly.
Yes, sir.
So basically, you need to, suppose a patient says he gets angina only at night, but not on effort. That's very typical of, either aortic regurgitation or because of incipient left heart failure. At one time, we used to say syphilitic aortitis. There, the cause is to be ostial stenosis of the coronary arteries, but the mechanism of angina there also is there's not only increased demand, but there also decreased supply because of ostial stenosis. But nowadays, we rarely see ostial stenosis of syphilitic origin. There are other causes. Okay, go ahead.
Yes, sir. There was no history of post-episodic diuresis, not associated with syncope and pre-syncope. Patient also complained of 2 to 3 episodes of chest pain, which was retroexternal. There was no history of hemoptysis, hoarseness of voice, swelling of lower limb, abdominal distension, limb weakness, altered sensorium, slurred speech, pain in extremities, blackening of fingers and toes, skin rash, night sweats. Past history, Patient has history of fever with disabling joint pains at the age of 13 years and also history of hospitalization at that time due to sudden onset of breathlessness and chest pain for which he required oxygen support and IV injection and discharged after 1 month from hospital, after which he was started on injection Penidura as he recollects every 3 weeks, but he left the treatment after 5 years. No history of diabetes mellitus, hypertension, personal history, 4 siblings,
Go
other
back, go
siblings.
back, go back.
Yes.
So now you give a very important history. So what is this past history telling you?
Sir, past
What do you
history.
think this is?
Sir, patient had a complaint of disabling joint pains with fever.
What is this? What is your interpretation of this?
Most likely, sir, possibly suggestive of acute rheumatic fever, sir, at this time, sir.
So high possibility of a patient having an acute rheumatic fever. In fact, it is very clear because the patient has been on Penidura, must have been diagnosed by a physician, isn't it? So this limits your complete system and the whole approach to an episode of a acute rheumatic fever. And he has been on a Penidura. How many patients typically recollect that they have a past history of rheumatic fever?
Sir, around 50%, sir, patient recollects history of acute rheumatic fever.
50 to 60% patients typically will have. We'll come to that more. So you should be able to interpret every time, isn't it? Go ahead now.
Now, in rheumatic fever, which joints are not involved in the clinical manifestation?
Sir, axial skeleton is not involved, sir.
No, tell us in plain English words.
Sir, vertebra, sir, is not involved, sir. Back spine is not involved, sir. And, sir.
No, basically, this is a involvement of what type of joints?
Large.
Large joints, sir.
So, which large joint is rarely affected in rheumatic fever?
Sir, hip joint, sir.
No. Hip joint is rarely affected, just as shoulder joint is also rarely affected.
Yes.
Go ahead. Please go ahead.
Yes. Personal history, 4 siblings, other sibling younger than the patient, and all are disease free. Patient belongs to lower socioeconomic status according to modified Kuppuswamy scale. Patient is vegetarian, sleep normal, appetite normal, bowel and bladder habit normal. Family history, no significant family history. Has 2 child, and both are disease free, sir. Married. Now, should I come to the summarization?
Yes. Personal history, yes.
Sir, 42-year gentleman with progressively increasing dyspnea on exertion for last 10 years, with NYHA class 2 to class 3 in last 1 year, with history of PND for 1 year, with palpitation for 5 years, which was pounding in nature, most likely volume overload palpitation, with 2 to 3 episodes of nocturnal angina in last 1 year, with history suggestive of possible acute rheumatic fever at the age of 30 years, with penicillin prophylaxis for last 5 years.
You should say that it is a 42-year-old gentleman with a progressively increasing dyspnea over last 10 years from NYHA class 2 to class 3 with 1 episode of PND. Okay, perfect.
Yes, sir.
So what is your interpretation and what is the possibilities? Definitely you have limited it to as very clearly evident as a valvular heart disease. So what are the possibilities if this acute rheumatic fever history has to be taken and if it is not to be considered? Okay. If this ARF history was absent, then what are the possibilities you would have considered? And if ARF is present, obviously we will be interested in what kind of involvements you are looking at. Okay, go ahead.
And from the DD, sir, most left-sided stenotic lesion at AV valve with regurgitant lesion possibly at AV valve or aortic valve of rheumatic etiology. If ARF history is absent, then maybe bicuspid aortic valve with severe AR with LV dysfunction and small to moderate size VSD with severe AR, sir. These are my differential diagnosis.
What do you think is the cause of heart failure during the acute rheumatic fever?
Yes.
Sir, it is due to, sir, carditis, sir.
Carditis? You have to elaborate,
Yes, sir. Sir, it's valvulitis leading to sir, leading to sir,
Acute MR,
acute MR, acute AR leading to sir,
Acute MR?
sir, acute LV dysfunction due to sir carditis leading to
Wait.
acute myocarditis.
Is there LV dysfunction in acute rheumatic fever?
no sir.
Then you're telling LV dysfunction.
Sir, carditis leading to severe MR.
No. That's why I said, is it a muscle problem or is it a valve problem? That is
Valve problem, sir. Valve.
Then why are you involving muscle?
Muscles.
So what does that indicate? A patient going into severe heart failure during the episode of acute rheumatic fever, which valve is most likely to be causing the problem?
So mitral valve, sir.
Mitral valve. So it must be having severe mitral regurgitation. What is the mechanism of regurgitation in acute rheumatic fever?
Sir, valvulitis leading to sir. Leading to sir severe MR.
What does it cause?
Mechanism is the level of the leaflets, level
Yes,
of
sir.
content, level of annulus.
Sir, at leaflet, sir, there will be sir a defect in the
Sir is
coaptation.
asking,
No,
where is the problem? Is it at the annulus or the leaflets or somewhere else? What happens in acute rheumatic fever?
Sir, leaflet, sir,
Leaflets.
severe MR.
In severe MR, yes. Yes. Which one is common? In mitral valvulitis? Obstruction or regurgitation?
Regurgitation is common, sir.
More common. So what is the why it is too? Due to ring dilatation? Or in the valve
acute
deflex?
situation.
Huh?
You are asking in the acute situation, what is the most common cause of regurgitation lesion causing the heart failure? Whether this is because of the structural damage of the valve leaflets or it is because of the annular dilatation.
Damage of the sir valve, sir. Valve.
My question to you is, the mitral valve apparatus consists of how many components?
Sir, mitral valve apparatus consists of sir valve and then annulus, then sir chordae, and then papillary muscle and muscle, sir, LV.
Okay. So which component of this mitral valve apparatus is abnormal in rheumatic carditis, which is responsible for mitral regurgitation?
Sir, valvulitis, sir.
No, valvulitis is a
Valvulitis, what is the component? Nah, sir is giving again and again. He's asking the question third time. There is something that is going in the apparatus which goes wrong, na? That causes severe MR.
Which part?
Which part? It's in the
Sir,
in what?
Sir.
Does it resemble like a mitral valve prolapse?
Yes, sir. Yes, sir.
Why it is? Why is it prolapse is due to?
Sir, prolapse due to sir defective coaptation and
due to
sir defective coaptation, sir, thickening of the valve leaflets leading to the
or something in the defect in the supporting structure. You have to
annulus, sir. Annulus.
Not annulus.
Papillary muscle dysfunction.
Now, I think you go back and then read about pathology of the acute rheumatic mitral valve pathology.
Yeah.
Okay? We will not, because time is going on. Go ahead.
Yes.
Go ahead.
So you limit your diagnosis to a stenotic lesion probably at the atrioventricular valve, or you want to say a mitral stenosis and possibility of a aortic regurgitation. So now when you will be presenting and besides this, as sir has said, you should know all the nuances. Everyone who is listening know all the nuances about the acute rheumatic fever. What is the etiology, pathophysiology, which age it is common, why, and what changes have been occurred in Jones criteria, what have been the modifications that have been done, And
Yes.
why subclinical and clinical carditis was included in 2015? What are the 3-4 important studies for that? What is low prevalence? What is high prevalence clinical
Yes.
subclinical carditis? Every nuances, because we don't have the bandwidth, but these are the questions that you will be asked, and you should be knowing about that. The pathophysiology of mitral regurgitation. What is the natural history of this mitral regurgitation? How many of them develop? Why penicillin is given? In what dose it is given? Why 4 weekly? Why not 3 weekly? Why 3 weekly? Why not 4 weekly? All these things, what are the evidences for that? What are the management strategies? Everything about a traumatic fever in pre and post penicillin era, you should be knowing about. Penicillin decreases mortality by how much? These are the questions that will be pouring on you, that will be definitely asked to you, especially when you clearly say there's an acute traumatic fever. The examiner will stop and will pour all these questions to you. So we don't
Right.
have time, as sir has said, so we will move ahead. And now, when you are presenting an examination, everybody should listen. When you make a differential diagnosis, your examination should be guided to rule in and rule out something. Rule in what, or approve what you have made a diagnosis, or rule out what you have made not committed. Okay, so this is how your every single finding should be interpreted. That is the art. So it's good. We have not touched the patient. Without touching on the basis of acute traumatic fever history with presence of dyspnea and palpitations, we know yes, there is an involvement, probably a stenotic valve, and somewhere also regurgitation at the aortic valve. Now go ahead with the examination.
On examination, patient was conscious, oriented to time, place, and person, sitting comfortably on bed. BMI 23.5 kg per meter square. Pulse 90 beats per minute, regular. High volume, bounding. Waterhammer pulse with characteristic Whisperian's pulse felt in the carotid. All peripheral pulses were equally palpable, and there was no radio-radial and radio-femoral delay. Blood pressure, right upper limb 150/50 and left upper limb 146/50. Right lower limb BP 200 mm of Hg systolic blood pressure, and left lower limb BP 196 mm of Hg systolic blood pressure. JBP not
Go
raised.
back. Now, you have a Bispherian's pulse, a high volume pulse, and blood pressure, which is almost diastolic is approaching low. What does it tell you? What does it confirm or tell you? It's a
regurgitant lesion, sir.
definite regurgitation. So your previous diagnosis of aortic regurgitation is significantly supported by this finding. Yes or no?
Yes, sir. Yes.
A typical Bispherian's pulse, isn't it? What is a
Yes, sir.
Bispherian's pulse?
Experience pulse are there two peaks, percussion wave and tidal wave. In between there is not. There is two peaks, sir.
Both the peaks in systole,
Systole, sir.
systole
Both
and
the
one in
peaks are in
diastole.
systole, sir.
Which is the pulse which has one peak in systole and one in diastole?
Sir, dicrotic wave, sir.
So this is how your Viva will be wavering around, isn't it? So that's a Waterhammer pulse. Which artery is best palpated for a Bispherian's pulse? Demonstrating all these things will be asked. Okay, go ahead now.
No, I have one question to the candidate.
Please, sir.
Doctor, how did you measure the blood pressure in this patient? Which instrument have you used?
Sir, sphygmomanometer, sir, we use, sir, blood pressures.
Are you allowed to use a mercury manometer now?
Sir, because, sir, mercury blood pressures are, sir,
Do we use mercury is not available in the hospital? How can you use it? Sir is asking which blood pressure instrument do you use?
Aneroid.
Aneroid.
Okay, that
Yes, sir.
the problem here is if you are going to use a NIBP, you will never get the true diastolic blood pressure. That is the problem with some of these candidates. They are measuring it and then pressing the button, and whatever number the machine is giving, they are taking it as diastolic blood pressure. Now, go ahead, be that as it may. Continue the presentation, doctor.
Continue,
yeah, please.
Yes, sir. JBP not raised, normal wave pattern, peripheral sign.
No, wait a minute. This is very important. In the valvular heart disease, you just can't dismiss it saying that JVP not raised, normal wave pattern. What is the response to respiration?
Sir, during inspiration, sir, there is decrease of the positive waves, that is A wave is decreased, sir.
No, but basically you say JVP not elevated. Waveform, you'll have to describe it. Suppose you find a tall V wave, what is your diagnosis?
The tall V wave, maybe such patient has severe TR, sir. That will be
What about the Y descent?
Y descent will be, sir, blunted, sir.
Blunted.
Blunted?
Blunted.
Sir, in severe TR, sir.
No. In this patient, we're not talking about theory. Now, I'm trying to ask you, when you describe jugular venous pressure,
yes, sir.
Describe whether the pressure is normal or raised. Then if the pressure is raised, what about the pattern of the waveforms? And each individual wave has to be described properly.
Sir, A and
B wave and A wave is present, not present.
Yes, sir, present. A wave present, 2 positive waves and 2 negative waves, sir. A and V wave present and X and Y descent seen, sir. X and Y descent more prominent.
No. Wait. How did you identify X and Y at the bedside?
Sir, X and Y descent we will correlate with, sir, sir, heart sound, sir.
How did you do it? Just tell us.
Sir, before first heart sound X descent and after, sir, second heart sound Y descent, sir.
Totally wrong. X descent is systolic or diastolic?
X descent is, sir, systolic, sir.
Then how can it be before first sound?
After, sir.
After S1.
After S1, sir, X descent, and after, sir, S2 Y descent, sir.
No, these are all important. That means you're taking it very casually. Whether you say you have not done it properly, or if you do it properly, you have to tell it properly.
Yes.
What is the implication of an A wave here? A wave was normal or abnormal?
Sir, normal, sir. No.
Normal. So it was not very prominent. So what does that mean? Presence of a wave means what? What is the implication?
Sir, implication is that there is no RV dysfunction or severe PH.
Wait. What does the A wave got to do with RV dysfunction?
Sir,
A wave is due to? A wave is due to?
atrial contraction, sir.
Contraction. So that means patient is in what type of rhythm?
Sinus rhythm, sir.
Yeah.
Complete heart block will be prominent.
Markedly increased in amplitude, then there may be tricuspid stenosis.
Yes,
or
sir.
Hypertension if there is no tricuspid valve lesion. No, you
Yes,
need
sir.
to be a bit more descriptive. It is a very casual approach. Go ahead.
Yes, sir. Peripheral sign, heel signs are present, 54 mmHg, top sign present, Durojet sign present.
Wait. All this, heel sign, has it got any relevance in 2025?
No.
Then why are you mentioning it?
Hill sign is not important. Yes.
Yeah, so peripheral signs, they are all outdated, utility of these physical signs. They got no meaning and no hemodynamic correlations.
Master Class.
Okay, go ahead.
Yes, sir.
No signs of erythema marginatum. No, you just go back. What is erythema marginatum? Can you just describe it, doctor?
Sir, erythema marginatum, it's
Have you seen any case of erythema marginatum in your training period? If you are in the final year student, have you ever seen a case with erythema marginatum?
No, sir. No.
So how do you elicit that? Which portion of the body it is present? Is it present on the face or on the legs?
Sir, it doesn't involve face, sir.
The trunk.
Trunk.
It involves only the covered portion. Covered portion of the body.
And expands, sir, centrifugally, sir.
My simple advice to you is, if you are not confident about a physical finding, don't describe it and then get into difficulty.
Yes.
If you are not sure of it, just don't say it. Examiner is not going to ask you what is not written there.
Right.
Yes, sir.
Where do you see subcutaneous nodules?
Sir, extensor surface, sir.
Where?
Sir, joint, sir. Joint.
Yeah, around the joint. Yes.
No. I just want to ask you, what is the clinical implication of a subcutaneous nodule in a patient with rheumatic fever?
Sir, subcutaneous nodule is associated with carditis, sir.
No, does it appear early or late?
Sir, early, sir.
Totally wrong. Totally wrong. Subcutaneous nodule appear latest. If you see a patient with rheumatic fever with subcutaneous nodule, then the disease has been there for at least 3 to 4 weeks.
2 to 4 weeks, yeah.
And 90% of the patients having subcutaneous nodules will have carditis, whether you recognize it or not. Subcutaneous nodules have got a lot of meaning and purpose, especially in rheumatic fever. Okay, go ahead.
Which is the other manifestation of acute rheumatic fever that is invariably associated with carditis besides subcutaneous nodules?
Sir, that is, sir.
एक ही तो बचा. चलो आगे.
It's Korea, sir.
Yeah.
No. Korea is again a late presentation, na?
Yes, sir.
Yes, it suggests carditis, but it's late.
Go ahead.
Right.
On serious examination, on inspection, chest bilateral symmetrical, no prominent vein and no scar mark. Apical impulse seen in inframammary area around 3 to 4 centimeter below the nipple. Supraesternal pulsation visual. No epigastric pulsation, no parasternal pulsation. On palpation, apex bit located in 6th intercostal space, 2 centimeter lateral to mid clavicular line, ill-sustained and hyperdynamic in nature. S1 not palpable, no palpable S2 and parasternal hip. On auscultation, S1 soft.
Wait. Go previously. Intramammary area around 3 to 4 centimeter below the nipple.
No, he is talking about the. I think your palpation findings suggestive of the which chamber is enlarged. Is right or left ventricle?
Sir, left mostly.
Left ventricle. And you also don't get any palpable S2.
Yes, sir.
So that means the patient does not have any evidence of significant pulmonary arterial hypertension.
Right.
Sir, P2 was loud, but I did not get sir palpable S2, sir.
Okay.
Wait. What is your criteria to say P2 is loud?
Sir, when P2 is heard at the apex other than sir second left intercostal space, then sir P2 is loud.
So what is the exception to the rule?
Sir, exception.
You can have P2 audible at the apex and still not have pulmonary hypertension. You are aware of it, not aware of it?
P2 at apex. No, sir.
In patient with ASD or a markedly dilated right ventricle, you can hear this at P2 at the apical area and still not have pulmonary hypertension.
Yes, sir.
The comparison, in case of loudness of the P2, you can do in 2 ways. One is compare the intensity of this P2 with A2.
A2, exactly.
And then whether P2 is heard widely or localized. Normally, P2 is very localized and is much less intense as compared to A2.
Right. Yes.
So basically, all said and done, we still have got a lot of what you call discrepancies between clinical evaluation of P2 and actual hemodynamic findings. Go ahead.
Sir, on auscultation, S1 soft, S2 hard with narrow split, A2 soft with loud, P2, S3, S4 not hard.
Wait. Please wait. What is your definition of narrow split?
Sir, narrow split when we are not able to differentiate generally during
wait. We'll have to define because you have written down there.
Sir, during inspiration they split and expiration they A2 P2 is not recognized. That is
normal.
Yes. Inspiration they.
That is normal. Audible split during inspiration and single second sound in expiration is normal.
Sir, on inspiration also, if we are not able to, the A2 P2 is not split, then it is narrow split, sir.
Then if you are hearing only one sound, where is the question of split?
Yes, sir. Yes.
No. I think I think we have to stop using that term narrow split. If it had been wide split and then become narrow, it's totally different from your description. So what is the normal split?
Normal split, sir. First A2 and then P2, sir.
No. At the bedside.
Yes, sir.
At the bedside, when do you say the splitting of the second heart sound is normal?
Sir, when we hear during inspiration A2 and P2 separately, and during expiration, sir, the A2 P2 is not heard separately. Then it is,
So
sir.
it is single in expiration. So what is a wide split then?
Sir, wide split, sir, during if during inspiration, if sir, if we compare sir, during expiration also, if there is split, then it is a wide split, sir. Depending on the whether it is variable or fixed, sir.
Okay. Then what is paradoxical split?
Sir, if on sir inspiration, when we split is audible in expiration, but if we hear in inspiration also, then it is paradoxical split, sir.
No, that is not.
Inspiration may no split and split in expiration is paradoxical split.
Yes, sir.
No. You see, the problem here is there's nothing like a narrow split. Okay. So please don't keep on writing that narrow split business. A2 soft in a patient with aortic regurgitation. What does that exclude?
Sir, in A2 is soft, sir. The exclusion is, sir. They will be, sir.
Aortic root dilation is
Right. So what is the importance of second heart sound in patients with aortic regurgitation? If the
Yes,
A2
sir.
is soft, usually the pathology is in the leaflets.
Yes, sir.
If the A2 is loud, like tambour quality,
Aortic root
the
dilation.
aortic root is dilated, which is responsible for AR. So
Yes, sir.
by saying A2 soft, you are telling that the pathology is in the leaflets.
Yes, sir.
Okay, go ahead.
A holodiastolic high-pitch murmur blowing decrescendo in
Wait.
configuration.
Kindly wait. Additional sounds.
Sir, opening snap is present, sir, which I have described in it, sir.
S3,
Sir,
Opening.
no
you are
S3,
telling
S4, sir.
He has
No,
written
he is telling, you are telling the faster sound is soft, and you are telling there are opening snap. So how do you, correlate with the faster sound and opening snap? Soft faster sound and opening snap.
Sir, opening snap it's diastolic, sir, and if it A2 P2 and then another sound is occurring, then it is probably opening snap, sir.
So do you find opening snap in any regurgitant lesion?
Sir, less likely, but sir, patient it hard in the patient, sir. So,
So what is the most common cause of opening snap?
sir, mitral stenosis, sir.
Yes.
But here you are telling the faster sound is soft.
Yes, sir.
So how do you correlate if there is a significant mitral stenosis in that, and you are telling there is a regurgitant murmur? So that is, you are talking about the aortic valve origin, the regurgitant murmur.
Sir, maybe it associated with severe MS. And severe AR associated, so there will be maybe S1 is soft due to
No. Wait.
associated.
Simple question is, can you have mitral stenosis with soft first heart sound?
No, sir. There will be loud S1, sir.
Loud S1. Suppose if the valve is calcified.
Like calcified will soft.
Yes, sir. If
Sir
there
is
is
simply
severe
asking you
calcified.
that what
No,
are the
you
causes?
need to
Listen,
understand all those things.
Simple thing, sir is asking that there is nothing absolute in cardiology. Not all MS will have a loud S1. So what are the causes? There are 7-8 causes you should know. Calcification is one of them. Even an obese guy you would not be hearing. There's so many causes. So you should
MR, sir, associated
Yeah.
MR.
So you should be aware of all these things. Listen to the questions. Chalo, go ahead.
Yes, sir. a holodiastolic high-pitched murmur blowing decrescendo in configuration, best heard in third left intercostal space in sitting and leaning forward position at end expiration with the help of diaphragm of stethoscope with increased isometric hand grip suggestive of aortic regurgitation. A mid-diastolic murmur, low-pitch rumbling murmur, best heard with the bell of stethoscope in left lateral position with opening snap with pre-systolic accentuation to MS. A grade 3 by 6 rough and harsh medium to high pitch early peaking ejection systolic murmur in right second intercostal space close to the sternum, better audible with breath held in expiration with the diaphragm of stethoscope radiating to bilateral carotids.
Right.
So what is the mechanism of this systolic murmur in your case?
Sir, due to functional aortic stenosis, sir.
So you have recorded the blood pressure systolic high, no?
Yes, sir. Yes, sir.
Then if you say
Flow murmur, sir.
No, if you say aortic stenosis there, and you have recorded the water hammer pulse, so how do you explain?
Sir, can we repeat the question, sir?
The sir is asking that you have said that it's a aortic regurgitation murmur. How can you explain a harsh systolic murmur? In other words, can this grade 3 by 6 harsh systolic murmur be present in a case of aortic regurgitation? Yes or no?
Yes or no? Yes.
So if it is yes, what are the possibilities?
Yes, sir. Yes, sir. Due to large volume of blood, sir, going through may produce, sir, functional murmur of aortic stenosis, sir, flow murmur, sir.
Can the functional murmur of aortic stenosis even radiate to the carotids? Yes or no?
Yes, sir. It may
Yes, it can.
Yes.
So
Yes.
third thing, so you have to defend that. And the
I have one question to the candidate.
fourth thing is, why do you think it is not definitely a severe aortic stenosis or a functionally very important aortic stenosis? Tell me why. Why?
Sir,
Look, think before you answer. Why it is not a significantly clinically significant aortic stenotic murmur?
that is early peaking ejection systolic murmur. So ruling out, sir.
No. What are the other findings?
Blood pressure.
Blood pressure is, sir, on the higher side, sir.
None of the accessory findings. Look at the pulse. Look at the blood
Pulse, sir.
pressure. Isn't
High
it?
volume pulse.
High
No,
volume.
I have one fundamental question to the candidate. He has described everything about murmur except the most important one. Most important one in all the murmurs, there he has described the pitch and then the character and other things. But he failed to describe the duration of
the murmur.
Sir, holodiastolic, sir, of AR murmur, and sir, mid-diastolic murmur is short only, sir.
Where is it written?
So holodiastolic means it's a severe or it's a moderate?
Severe, sir, severe.
No. Hollow diastolic, high-pitched murmur. What do you mean by hollow diastolic?
Sir, starting from, sir, S2 to whole of S1, sir.
No. Just describe what you meant by hollow diastolic.
Holodiastolic, sir, long diastolic murmur, sir.
Long means what is your definition of long?
Entirety of diastole.
Throughout the diastole?
Throughout the diastole, sir.
So throughout the diastole. So it must be, but what about the MDM?
Sir, MDM, sir.
I have not written anything there.
Sir, MDM murmur is heard at the, sir, apex, sir, and
No,
holodiastolic
duration of the murmur, sir, I am asking.
Sir, MDM murmur is a short with pre-systolic accentuation, opening snap followed by mid-diastolic murmur.
No, I am asking you, what is the duration of the mid-diastolic murmur?
Sir, short duration, sir, short duration.
Less than half of.
Less than half of diastole.
No, in every description of the things, you have said so many other things which are not relevant, but the duration of the murmur is missing. Why are you emphasizing at the level of DM student, best heard in with diaphragm of the stethoscope? What are you trying to convey?
High pitch, sir, diaphragms.
What exactly you mean by pitch, doctor? At the bedside.
From his clinical finding, what I see that predominantly, as he said, starting from the left ventricular apex and the predominant pulse of water hammer's nature, and the murmur is also the holodiastolic murmur, and he is talking about a MDM. So predominantly he is dealing with a case of predominant AR, I believe. Now you tell me, if there is a predominant air and you are getting the mid-diastolic murmur at the apex and the S1 is
With the-
soft.
yes.
How do he told the S1 is soft?
Yes.
So then in
How do you
that case,
correlate?
how can you differentiate between a mid-diastolic murmur of organic MS or Austin Flint murmur in your case?
Sir, they stated loud P2, sir, sir, Austin Flint murmur, if we differentiate between the murmur of MS and Austin Flint murmur, they will be stated loud P2, the suggestive of sir, stated mitral stenosis, and sir.
Wait. Is this diastolic murmur associated with a diastolic thrill or no diastolic thrill?
Sir, I was not able to appreciate, sir, diastolic thrill, no diastolic.
So suppose if there's a diastolic thrill at the apical area, what does that rule out?
Sir, is AR, sir, Austin Flint murmur, sir.
So that is simple, right? Instead of telling so many things. If
Yes,
it is
sir.
there, can you have Austin Flint murmur with a thrill at the apical area?
Austin Flint murmur with thrill, sir.
Has it been described? It won't occur.
Yes, sir.
Supposed to be a functional murmur.
Yes.
Yes.
So basically, you are not utilizing all your what do you call bedside physical signs. That is the problem.
Yes. S1 is soft.
Yes, sir.
In organic MR, organic MS, S1 cannot be soft, na? Except in acute rheumatic fever. Right?
No, but it can also be due to a calcified wall. One of the problems is that the description is being very suboptimal as far as the murmur description is concerned. You're supposed to describe 6 components of the murmur. You go back and read the Hutchison Hunter again.
No, in his history, he has told about the evidence of paroxysmal nocturnal dyspnea suggestive of left ventricular dysfunction. Now the point is, how early you get the evidence of left ventricular dysfunction in a predominant AR?
Sir, only advanced when severe AR with LV dysfunction occur, then only we get PND, sir.
So it is not a very early feature, no? The left ventricular dysfunction with significant AR is the predominant lesion. So usually you take long. Which lesion gives the early evidence of left ventricular dysfunction or left heart failure? Which lesion out of the aortic and the mitral valve, which lesion gives the early evidence of left ventricular dysfunction or left heart dysfunction?
Which one?
I think it's more appropriate to say left heart dysfunction.
Left heart dysfunction.
Yeah.
Sir, between aortic valve or mitral valve?
Which lesion gives early evidence of left heart dysfunction?
Sir, severe MR.
Very rare. You don't get it that very soon. What is the clinical evidence?
S3, sir. S3, sir.
Dysfunction for left ventricular dysfunction.
S3, sir.
Suppose if there is severe MR, what is the implication of S3 as compared to S3 in AR?
S3 can be physiological in severe MR as well as pathological, sir.
No. You have to say what is the implication. Suppose if I'm hearing a S3 in a patient with pure isolated severe MR, the implication is MR is severe. Whereas the implication of a third heart sound in aortic regurgitation is almost always a sign of LV dysfunction.
LV dysfunction, yes, sir.
Yes.
So basically now you're telling there is LV dysfunction and you're telling it is a severe AR and there is no mention of S3.
Sir, I'm not, with the LV dysfunction, I'm not committing, sir.
You're not committing because?
Sir, because, sir, there is, in pulse, sir, there is, sir, pulses experience is present and mid-diastolic murmur is due to, sir, severe MS. So,
So what is the cause of recurrent nocturnal dyspnea?
Yeah. That is.
Due to such severe AR, sir, nocturnal angina.
Okay, we'll come back to that when we are looking at the investigations. Proceed further.
Yes.
Yes, sir. So final diagnosis is rheumatic heart disease with severe MS, with chronic severe AR, with severe PVH, with moderate PH, with history of rheumatic fever in the past, with NYHA class 3, with a normal sinus rhythm, with no signs suggestive of congestive heart failure, infective endocarditis, and acute rheumatic activities.
Is it acute rheumatic heart disease, doctor?
Sir, no sign of acute rheumatic activities.
So why are you writing rheumatic heart disease? What should I assume?
Chronic rheumatic heart disease, sir.
Chronic rheumatic. What is the functional class?
Sir, functional NYHA class 3, sir.
Right now he is in class 3, is it?
Yes, sir. Right now in class 3.
You are written down with normal sinus rhythm. Is there anything like an abnormal sinus rhythm?
Sir, not in AF, sir.
No. You have written down there with normal sinus rhythm. I'm asking you, can there be any abnormal sinus rhythm?
Sinus tachycardia, sinus medical.
See, you should avoid telling such word, the normal
Yes, sir.
sinus.
With sinus rhythm. Sorry, sir.
With sinus rhythm. And no signs suggestive of congestive heart failure. Congestive heart
Yes.
failure is a diagnosis of what is your definition of congestive heart failure?
The patient had, sir, crepitations, elevated JVP.
No, kindly listen. What is the universal definition of heart failure as described by the ACCH?
Sir, heart failure defined as inability to meet metabolic oxygen demands of the body, in spite of, defined as heart failure.
Go back and read the definition, doctor. That is not what is given.
Current definition by ACCH.
Yes. And that is called a universal definition of heart failure.
Heart failure.
Yes. Yes.
So you should, that is not the way it is described. So is heart failure, is it a clinical diagnosis or a laboratory diagnosis?
Heart failure, both are clinical and laboratory both.
So what laboratory tests you want to have to confirm the diagnosis?
Sir, we can do, sir, investigation of NT-proBNP and see the grade.
Can you
Then
have
we
heart failure with normal NT-proBNP?
Yes, sir.
Like? In what condition you will get it?
Heart failure with normal, sir, can you repeat the question? I was not.
Heart failure with normal NT-proBNP.
Sir, in falsely low NT-proBNP level in obese patient and CKD patients.
No. We are talking about cardiac conditions with heart failure and normal or low NT-proBNP.
Sir, constrictive pericarditis patient.
Constrictive pericarditis, we call it as a heart failure, is it?
Sir,
the usual type of heart failure you see in your day-to-day work, wherein clinically it is heart failure, and NT-proBNP says only
heart failure with preserved ejection fraction.
Then we should say that first. Why the NT-proBNP is normal in heart failure with preserved ejection fraction?
Sir, NT-proBNP.
There is a sign of that stretch of the atrium and commonly the heart is small.
The reason for normal NT-proBNP in patients with heart failure with preserved ejection fraction.
Sir,
small heart.
Small heart. That is a. Is it a small heart or small LV cavity?
Small LV cavity.
Small LV cavity.
No chamber dilatation.
No
Right.
chamber.
The wall thickness is more. So what happens to the wall stress?
Increase, sir, stress will be.
No. So now you will have to tell me what is wall stress there.
Wall stress is proportional to radius of the LV.
That's all. It is
And, sir-
directly proportional to the cavity size and inversely proportional to.
thickness, sir.
So if the wall is thickened, the LV wall stress will be high or low.
Low, sir.
Then that is the reason. Second reason is that majority of the patient with heart failure with reduced ejection fraction, with preserved ejection fraction, they are obese. So why the NT-proBNP levels are low in patients who are obese?
The BNP is metabolized in
What do you mean by
in
metabolized?
level in obese patients, sir.
What is the so-called metabolism of your NT-proBNP? How do they distribute the circulation?
It is due to the stretch atria release ANP and
No,
BNP.
not release. I'm asking you, how are they disposed of from the body? Why the NT-proBNP levels are high in CKD?
Urinary excretion.
Urinary excretion of sir.
So any other organ in the body which metabolizes the NT-proBNP?
Sir, liver, sir.
Liver. So you go back and read about the metabolism of your BNPs and NT-proBNP.
Adipose tissues.
So that's it. So
Yes,
adipose. Okay, go ahead. So but this patient,
No.
your
No,
evidence
I
for
like
heart failure here is in this patient. What is the evidence? You said JVP not elevated, no edema.
sir, I mean no sign of congestive heart failure.
With no signs of congestive heart failure. Okay.
Now you tell me, what are the evidences of severe MS in your case?
Severity बात का बात है.
Sir,
You have said severe MS. So what are the evidences you have mentioned?
Sir, from history, patient is complaining of dyspnea on exertion for last 10 years. And sir, patient is having NYHA3 class. Second, sir, in sir examination, sir, there is sir, a patient has mid-diastolic murmur with pre-systolic accentuation, sir, PND, history of PND, sir.
That could be in. Now, what about the A2OS gap?
Sir, A2OS gap, sir, inversely proportional to A2OS gap, sir. This.
I have
Could you
the candidate. Are these rules applicable in multi-valvular heart disease?
Yeah.
Yes, sir. Sir, not applicable, sir, in multi.
Then why are you keeping on harping so about these intervals? Those intervals are valid in isolated mitral valve disease. Okay?
Yes, sir. Yes.
So in multi-valvular, in the examination, you'll have to defend. If somebody says, sir, you have not mentioned S2OS interval in your presentation, he said, sir, S2OS interval is not relevant in the presence of a multi-valvular heart.
Exactly. Right.
Yes,
So
sir.
you should be able to defend your answers. Is how you present and how you defend your presentations, how you defend your physical science, how you defend your statements there. That's important. Not just getting the diagnosis is only one aspect of it.
Yes, sir.
So what is your definition of a severe AR?
Sir, severe AR definition, sir, eco-wise or?
No. I'm asking you, what is your definition of a severe AR?
Sir, hollow diastolic murmur.
No, wait. What is the ACC-AHA, what do you call definition of severe valvular heart disease?
Sir, severe valvular heart disease patient is symptomatic and severe symptomatic patients.
That's all?
With NYHA class
No,
3
no,
to
no.
4.
Those are all, that is not that means you have not read that statements of ACCHA, valvular heart disease definitions. It depends upon the severity of the valve abnormality coupled with consequences on systemic circulation, pulmonary circulation, and consequences on the ventricular function. You have to combine all the three components. Based on those three components, you'll have to say it is severe or not severe. If you're telling about mitral stenosis, that is say, so the mitral valve area, then its effect upon the pulmonary vasculature, then its effect upon the ventricle, which is right ventricle or left ventricle, depending upon mitral stenosis or mitral regurgitation. So you go back and read the guidelines of definitions of, that's how there is a discrepancy in the statements of what is the criteria for a tight MS. So their criteria are slightly different from the Indian criteria. So what is your definition of a severe AR? You have to tell me now. How do you quantify the degree of regurgitation?
Severe AR, clinically, sir, we can
Not
quantify by
clinically. No, definition, hemodynamic definition.
sir,
In-
hemodynamic.
No, but in AR, what is the abnormality? There is regurgitation of the blood from the aorta into the LV. So the
Yes, sir.
regurgitant volume, regurgitant fraction, and then the regurgitant orifice area. These are the three.
Yes, sir. Eco-wise, yes, sir.
No, echo-wise, you can determine those things by any other methods. Echo is one of. Okay. So basically now you tell me the definition of severity of the AR based on effective regurgitant orifice area.
More than 0.3, sir, centimeter square.
You have to tell it properly.
ERO more than 0.3 centimeter square is severe AR with the regurgitant fraction more than 50%, regurgitant volume more than 60 ml.
Yeah, that's what all we wanted.
Yes, sir.
So how do you define the stenotic valve area? Stenosis.
Stenosis, sir, if in less than 1.5 to 1, sir, moderate, and less in Indian context, and less than 1 is severe MS in Indian, and according to sir SSCHA, 1 to 1.5 severe, less than 1 very severe, and less than 0.5 is critical MS, sir. 1.5 to 1.5 to 2 is sir moderate.
There is only one. That's only valve area. As I said,
pressure half times are more than 200 in severe MS, and sir, and with
peak gradient
and peak gradient more than sir 10 mmHg.
Do you take peak gradient or any other?
Mean gradient, sir, more than 10 mmHg, sir.
What do you understand by the word mean gradient as compared to peak gradient?
Sir,
what is the difference? What is the difference?
Sir, mean gradient mean of sir between peak and sir lowest gradient, sir.
No. You have to have a better definition. In a sense, it is a time integrated pressure. So
time velocity integral is
yes, sir. Time.
It is a time integrated pressure. The peak is highest pressure gradient. Mean gradient is a time integrated pressure. What is happening to the pressure gradient over a period of time of the entire duration of diastole in case of mitral stenosis? So you need to understand and be clear about what we mean by peak gradient and mean gradient.
Yes, sir.
So now how do you proceed to evaluate this patient?
Sir, I will go with sir ECG, chest X-ray, and echo and further investigations.
Can you show the ECG?
Yes, sir. Yes.
So this is the ECG of the patient, done at normal standardization, showing P wave and QRS rate of approximately 60 per minute, showing left atrial abnormality, left ventricular enlargement by the Sokolov-Lyon criteria.
No, kindly listen.
And
What is the QRS axis here?
QRS axis is around 30 degrees,
Minus 30?
the plus 30.
And what is the P wave axis?
And sub P wave axis is close to 0 degrees.
Close to 0 degrees. What does that mean?
So,
What is the normal P wave axis?
That shows that we have LA enlargement rather than RA.
You have to tell me what is the normal P wave axis. You're not sure?
30 to 60 is
Plus 30 to plus 60.
minus 30 to plus 60.
Okay, go ahead. Is there evidence of any left atrial enlargement here?
So PF duration is just more than 2.5. So borderline left.
Answer the question appropriately. Is there
It's a
any
left atrial enlargement.
P mitral is present in
P-mitral in V2. In the second lead, V2. Second lead.
P mitral is there? Define a P mitral.
notch between
Between the there's a notch in the mid P wave, and the duration is just over 2.5 small box.
Sorry. What is the duration you said?
So duration is 2.5 small boxes.
more than
2.5 small boxes. That is not the way. No.
And V1 they left negative
100 milliseconds.
Is there any evidence of ventricular chamber enlargement?
Then mala maatladutadu meeting lo unnaru.
Yes, sir.
So lead to they
No. You have to. P mitral definition is the P is wider and split, and both the peaks should be separated by at least 40 milliseconds. The total duration of the P wave should be more than 120 milliseconds. Go ahead. Is there a P mitral? I'm not convinced.
Yeah.
What is P terminal force?
in V1s are more than 0.04 second. Sir, negative terminal P wave in V1s.
So in a patient like this, now what you have told, in the absence of left atrial enlargement, do you still consider mitral stenosis being present?
So since we have left ventricular
No.
hypertrophy and no yes, then unlikely mitral stenosis will not be severe at least.
So mitral stenosis probably least likely based on the ECG. Okay, go ahead. Show us the X-ray and then.
Yes, sir.
Tell me,
So
what
this is
is
the
the diagnosis from the chest X-ray?
Chest X-ray is very interesting. Is there
Yes, sir.
evidence of left atrial enlargement on the chest X-ray?
yes, sir. There is double atrial shadow and evidence of left atrial and right atrial enlargement.
No. What is the most reliable X-ray sign of a left atrial enlargement with high specificity?
So the wide canal angle,
Is it wide here?
here it is 90 degrees. So
90 degrees. So according to you, it is high. Is there evidence of PAH here? X-ray wise?
So there appears to be the dilation of the right descending pulmonary artery, but this is not a standardized X-ray, so we cannot be exactly sure.
What do you mean by it is not standardized?
So this is a digital X-ray, so the scale is not exactly much.
No. That is not true. Even in digital X-ray, we do see it. We don't measure the absolute size, but we measure the relative size. Which one do you compare with? RDPA is compared with what? to say it is dilated?
Bronchus, sir. Bronchus.
With the bronchus relative, you can compare.
No. You don't compare with bronchus.
Okay.
The right descending pulmonary artery width should be more than the width of the trachea.
Exactly.
Hmm.
So it is trachea.
Yeah. So it is not bronchus.
Yes, sir.
So if it is more than the size of the tracheal width, then we say
Tracheal diameter.
DPA is dilated, which indicates that there is probably pulmonary arterial hypertension. Tell me causes of elevation of or increased size of the RDPA, right descending pulmonary artery, without PAH.
Pulmonary embolism, sir.
Pulmonary embolism, okay. One.
Then
Sir,
left heart.
Sorry? What happens in absent pulmonary wall syndrome?
severe PR, sir.
Dilated pulmonary artery and
But what is more prominent in this X-ray is dilated ascending aorta.
ascending aorta is dilated.
What is your criteria to say it is dilated? There are simple questions, but you have to know that. What is your criteria, doctor?
Yes, sir.
Criteria, sir. If ascending aorta.
So normally the upper portion of the right border of the heart, is it straight or curved?
Curved, sir. Curved.
Normal?
But in this is
Normally it has a straight, but here it is being formed by the
Yeah.
ascending
So
aorta.
that is dilated ascending aorta.
That's showing us.
So a patient with aortic regurgitation and dilated ascending aorta. So what is your diagnosis?
The severe aortic regurgitation patient with
What happens
moderate
in
to severe
bicuspid aortic valve?
bicuspid.
We have dilated ascending aorta is there, post-aortic dilation common.
No posterior, it is due to aortopathy.
Aortopathy. Okay. You can have just ascending aortic aneurysm with aortic regurgitation, or it can be a Marfan syndrome with dilated aortic root. So there are so many causes there. But anyway, we'll go to echocardiogram because we are nearing the time.
Yes.
Look at the LV.
Yes, sir. This is the parasternal long axis view showing thickened and doming of the anterior mitral leaflet and thickening and restriction of the posterior mitral leaflet.
Anything else?
And there is dilation of the ascending aorta.
What about leaflets? What about the leaflets? Aortic leaflets.
And aortic leaflets also seem to show thickening and doming.
No doming. They're freely moving. There's no doming.
Freely thickening and
next
non-cooperative. Next we can see.
Go ahead.
So on this view we can see dilated ascending aorta with non-coaptation in mid diastole.
And what about the left ventricular dimension?
Left ventricle is dilated.
Yeah.
What is the normal LA size? LA size here is normal or dilated?
It is dilated.
Sorry?
Dilated.
So what
So
is the normal size of LA? Echocardiography.
So LV.
No, LA.
LA is up to 4 centimeter in the long axis view.
So what do you compare with normally for LA size?
We can compare with the aorta.
Yes.
Yeah,
But
provided
since
the
aorta is normal size.
normal size, yeah. So absolute or relative? So relative aorta is how much here? Next
Here
page.
it's clearly more than 4 centimeters.
Mhm. When do you say it is requires surgical attention?
That depends on the etiology.
Mhm.
More than 5.5 centimeters
Mhm.
in the case of normal aorta or bicuspid aortic valve, and we use
Marfan syndrome is 5 and
5, and for
stated history
low SDH we can use 4.5.
4.5.
Okay, what about the LV function here? Can you see the data?
Next.
You have done the planimetry.
Yes, sir. Yes, sir.
Uh,
1.01
1 centimeters.
1 centimeters.
How much? How much?
1
One
centimeter, sir. Mitral valve area.
Mitral valve
1
area,
centimeter.
1 centimeter square.
So almost moderate stenosis.
Yes.
You have not
Severe
mentioned
moderate-
subvalvular
severe-
apparatus?
Subvalvular thickened, sir. In
Yes,
plaques,
you must
sir.
mention. It is quite obvious. Cortic tendons are thick.
And valve with calcified also, sir.
Yes.
Calcified and thickened anterior and posterior leaf lid.
So
That
go
is
for
the
the color Doppler.
that is the reason why your first sound is
Yes,
not
soft. Yes.
Yes, sir. Yes.
This is a colored Doppler across the aortic valve in the pastoral long axis view, showing severe AR with vena contracta of uh, more than 0.5 centimeter. This is the short axis view showing normal LV function.
Wait,
Yeah.
wait. How do you say normal LV in the setting of AR? What is
So
normal LV function in the setting of AR?
Normally function there is a EF, sir, more than 55%.
more than 55.
More than 55 or 60?
More than 55, sir. In recent guidelines, sir, more than, if less than 55, then we have
LV dysfunction.
Okay, go ahead.
So LV cavity is grossly dilated.
It's a four chamber view.
4 chamber view showing thickened mitral apparatus and dilated LV cavity and normal size.
And what was the LA dimension?
LA dimension appears to be normal.
Have you measured
around
the
4
LA
centimeters,
dimension?
less than 4 centimeters.
Sir, LA dimension, sir,
We have a
around, sir, 4.5. This is color Doppler.
color Doppler at the aortic valve in the 5 chamber view, showing
So-
severe aortic regurgitation.
No significant TRs.
No
No
significant TR
significant.
or MR.
That means it's a predominant AR because the LV cavity is mostly dilated.
Yes, sir. Yes,
Yes,
sir.
sir.
Severe AR with moderate.
Moderate MS.
Yes, sir.
Moderate MS and severe.
So what
And
are
good
the
LV
other causes of multivalvular heart disease other than rheumatic?
So we can have congenital mitral stenosis.
No, wait. I'm asking a question. What is the etiology of multivalvular heart disease other than rheumatic heart disease?
Connective tissue disorder, sir. In connective tissue disorder, like sir, sir, Marfan syndrome, sir, and sir, aortic ectasia, sir, Ehlers-Danlos syndrome,
No,
sir.
you're telling the same thing in
That's the same.
different way. All connective tissue disorders, you said. Anything else apart from that?
Sir, in achronosis,
Okay. How many cases you have seen? Achronosis? Common causes, a bit more common causes.
bicuspid, sir, aortic valve,
Bicuspid aortic valve is a single
single
multivalvular heart disease. What is carcinoid syndrome?
tricuspid valve.
Commonly involves tricuspid and pulmonary valve.
Tricuspid pulmonary valve. Can any drug cause valvular heart disease?
Yes, sir, methysergide
And
yes, sir.
anti-Parkinson's, cabergoline.
Yes, sir, cabergoline, methysergide and cabergoline.
Any therapies that can cause radiation therapy to the mediastinum?
Yes, sir, radiation therapy can
Cause any interventional procedure that can cause?
interventional, sir.
You don't have to be a very bad interventional cardiologist.
Sir, BMB.
BMB causes only MR.
Multiple.
So attempting to do more than one valve. Okay. So it's important to remember that there are other causes of, actually, there's a review article on multivalvular heart disease etiology. 10 causes have been described. They've been published in British Journal of Cardiology, that is heart, somewhere about 2007 or 2008. You can go through it. Okay, so what do you want to do with this patient? I think we are now almost reaching 420. Therapy for this patient. Medical
Sir,
therapy.
we will go with, sir, double valve replacement, sir.
So what are the indications, broad indications for valve surgery? Just broad.
The severe symptomatic valvular heart disease, either the mitral.
When you say severe symptomatic, which class?
MS or, and in this case, severe symptomatic AR, and even severe asymptomatic MS with other valvular severe MS, then.
No. What factors do you consider before you refer a patient of valvular heart disease to the surgeon? So one is symptoms, grade class 3 and class 4. Second category, class 1 indication.
So if LV dysfunction is present.
Very good. LV dysfunction. What are the class 2 indications?
Class 2, sir, other associated lesions, sir, other associated surgery, sir.
Yeah,
Other cardiac
surgery other than the valve, and then moderate stenosis of the thing. That is, any other class 2 indications?
Class 2, sir, if on AF pulmonary artery hypertension is
Right.
more.
So what is the pulmonary arterial hypertension criteria to say you can consider surgery?
On rest, sir, 50, and if on exercise more than 60, sir.
Okay. Why does the pressure increase in pulmonary arteries during exercise? Normally, does it increase, decrease, or remain the same? Pulmonary artery pressure. Normal person exercising, I'm talking about an adult between 40 and 50 years.
Yes, sir.
What happens to pulmonary arterial pressure during exercise? No change, increase or decrease?
There is systemic vasodilation.
No. Wait. First you give the answer and then justify.
Pulmonary artery pressure.
Normally, it's a decrease because we have increased ventilation. So,
sorry, normally.
So we have increased minute ventilation, which promotes pulmonary vasodilation and decreases.
I'm asking you a simple question.
Decrease
to the pulmonary artery pressure during dynamic exercise.
Sir, decrease, sir.
Decrease. Why should it decrease? Is there an increase in cardiac output or a fall in the cardiac output?
Increase in cardiac output, sir.
So increase in cardiac output should result in?
Sir, increase pulmonary artery pressure.
But does it increase? It does not increase. Normally, pulmonary artery pressure within the ages of 20 to 40, it does not increase because it is coupled with pulmonary vasodilatation.
Yes, sir.
Systemic vasodilatation Pulmonary vessels also dilate. But in very elderly, it has been shown that it can cause increase. But by and large, in a normal adult between the age of 20 and 40, with exercise, the pulmonary arterial pressure remains the same, no change. What happens to PA pressure during normal pregnancy? Increase, decrease, or no change?
Pregnancy. Sir,
No change.
What happens to cardiac output during pregnancy?
increase, sir,
Increase
increase.
in cardiac output, but no change.
So what happens to PA pressure? Increase, decrease, or remain the same? Normally, PA pressure remains the same.
Same.
Okay, so this patient, you are considering surgical intervention. Is there a role for TAVR and then balloon mitral valve? What?
Sir, TAVR, there is no data of TAVR in rheumatic disease, and for BMB we can do. Sir, there is severe calcific valve of mitral leaflet. So, in doing BMB, there is risk of severe MR developing. So,
For TAVR in aortic regurgitation is still in evolution. It is not the class 1 indication.
yes, sir, yes, sir.
This is not at all. Yeah,
Investigation.
that is true. Now, suppose if you want to use the prosthetic valve, now which valve you want to go for, the bioprosthetic or mechanical, and why?
So the patient age is 40 years, so we will use mechanical valve, sir,
Yes.
because it is more long lasting as compared to
Durability
bioprosthetic.
and the chance that we need reintervention.
Only thing you have to continue with the anticoagulant lifelong.
Anticoagulation.
Yes, sir. Yes, we have to continue.
Because they are
Our time is up, sir. Time is up.
Okay, you can continue 5 minutes. Yes. So final. So what is the mortality rate? Double valve replacement and single valve replacement.
Sir, in Indian setup, double valve replacement mortality rate is around 8 to 9%, and Western it is less, around 5 to 6, and in a single valve, sir, around 1 to 2%, sir. In Indian setup and in Western literature is 0.5 to 1% single valves.
Book says it is 10% dual double valve and 2 to 3% in single valve. Right. Okay. Sir, any more question?
Now, suppose now this patient is 40 years old, and you told there was also history of chest pain. Okay, and you are going for double valve replacement. Now, do you want to exclude any presence of coronary artery disease in this case?
Yes, sir. Yes, sir. We will do coronary angiogram. We do before, sir, in intervention, sir, in every patient.
Right. Okay.
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 So I think it was a very good demonstration of multivalvular disease, and Dr. Dayasagar has explained in detail all the facets of the clinical discussion, and I think all the postgraduates who are there are benefited with such kind of discussion, and hopefully they will face in this examination in DM final this kind of questions. So I wish all of them a very successful DM final examination. And I also extend my thanks to all the faculties who are present over there. So from my side, thank you and best wishes.
Thank you, Rahul. Thank you, Rahul and Ashish. You have done reasonably good. Yeah, you need little more reading and others. All right.
Thank you,
Dr.
sir.
Thank you, Dr. Gupta, Dr. Dayasagar Rao, Dr. P.S. Banerjee for your presence and taking part in an active discussion of this patient. Thank you. Here we have it is followed up. It is followed up by almost 250 students all over India.
Fantastic. Okay. Thank you.
Thank you.
Thank you. So we end the meeting here, master class program here, and we shall go next time in the next month. Okay.
Okay. Bye.
Bye.
Thank you, sir.
Thank you.
Recording